Thank you for joining us today. This webinar is being recorded, so if you have any objections, you may disconnect at this time. Thank you very much. On behalf of the National Cancer Institute, I wish to welcome everybody to the Implementation Science webinar series. We are excited to be joined by our speakers today, but before we get started, I want to discuss a few brief logistics. All attendees have been muted upon entry and will remain muted for the duration of the webinar. We encourage questions and comments using the Q&A feature on the right-hand side of your screen. Please type in your questions, select all panelists, and hit submit. Again, feel free to submit your questions throughout today's conversation. You may need to activate the appropriate panel using the menu options found at the bottom of your screen. And if you require closed captioning, please refer to the caption panel. We also recommend navigating to the View menu at the top left of your screen and selecting Hide Non-Video Participants for optimal viewing of our presenters today. And with that, I'd like to turn it over to Pranav Bhattacharjee.
Hello, everyone. Thank you so much for joining us for this webinar today. We're very excited to hear from members of the Consortium for Cancer Implementation Science Technology and Health Communication Action Group. Rachel Gold is one of the leaders of this group and is joined today by Constance Owens and Amy Hitchman. You can read their impressive bios by visiting the links on the webinar promotion page. We're very excited today to hear about a scoping review they have been working on as one of the public goods identified by this action group. And with that, let's turn it over to our speakers.
Thank you, and hello, everyone. Again, my name is Constance Owens, and I'm joined here today by Rachel and Amy, and we are pleased to share our presentation entitled Implementation of Health Information Technology Approaches for Secondary Cancer Prevention and Primary Care, a Scope and Review Preliminary Results. This review is led by myself and Rachel in collaboration with an outstanding team of members from NCI's Consortium for Cancer Implementation Science, in which we would like to especially recognize our co-author, Dr. Jin-Ying Ching, for her substantial contributions to this work. So when we go to the next slide, before we get started, please go to the next slide. Yep, thanks. Highlighted here are a few disclaimers we wanted to note. To include this presentation, we'll cover what we are learning so far from our research. So since these are preliminary results, the data we report today is subject to change. Next slide. And outlined here is an overview of what we will cover during today's webinar. Make sure you save your questions to the end. Next slide. So highlighted here are a few key evidence gaps that led us to this research. As we all know, there's a lot known about the effective screening guidelines for breast, cervical, and colorectal cancer. However, research shows that there are many people that are still not up to date with their cancer screening. So when exploring evidence-based practices to address this challenge in screening uptake, there is a need to understand if HIT is an evidence-based practice for cancer screening. And the short answer to this is yes. There is evidence that supports HIT effectiveness for cancer prevention as well as control. However, the question remains, what is known about how HIT tools improve the provision of guideline-concordant cancer prevention services? And this brings us to the last point listed here, which is there still remains limited evidence that focuses on what works best in primary care settings. So when we go to the next slide, in efforts to help bridge these current gaps, we turn to the integrated technology implementation model as our conceptual framework for this study. As we continue to grow in our knowledge of the intersection of implementation science and technology adoption in cancer prevention, we're finding there aren't D&I models that incorporate technology adoption. As illustrated here, the ITIM provides a cohesive model that introduces 12 inner and outer organizational concepts that are central to the process of both implementation and adoption of technology in healthcare settings. So now I'm going to stop and pass it over to Rachel to take us into our research questions and methods. Rachel?
Yeah, thanks, Constance. Next slide, please. Just again, so Constance really alluded to this in our previous slide, but just to be clear, what we wanted to do with the scoping review was get a sense of what is the state of the science on how HIT tools enhance the guideline concordant provision of secondary cancer prevention in primary care, and what is known about the adoption of these tools, barriers, facilitators, if the tools are effective, what do we know about how people use them and what the barriers are to that? Next, please. I want to spend a little time on this slide just being clear about the parameters of our scoping review. We focused on breast, cervical, and colorectal cancer screening because those are all screenings that take place in primary care, and they're common, and they are common cancers. The kinds of IT tools we looked at, we grouped into a couple different categories. We thought about those that are based in the EHR and based in the web. The kinds of functions that the tools provide include providing decision support, risk stratification, supporting outreach for patients due for screening, providing provider feedback on the rates of screening of their panel, et cetera. And then to be even more specific, what specific elements of cancer screening are supported by these tools? Is it panel management, figuring out which of your patients need to be screened? Is it identifying patients due for screening at the point of care? Is it acquiring previous cancer screening results that occurred outside perhaps of your setting? And is it ensuring appropriate follow-up for positive screening results? We, of course, are very much guided by implementation science in this work. The RE-AIM framework guided our analyses. We use the integrated technology implementation model constructs as another guide. And when we thought about implementation strategies that the evidence shows are used to support IT adoption, we use the ERIC taxonomy. Next, please. And I'm going to tear through these because I really want to spend time on the results. Just to say briefly, we went to all the usual data sources for the scoping review. We had a set of search term categories. The thing I always wanted to call out in this slide is that we look both at the peer-reviewed and the gray literature because, again, this is not a systematic evidence review. It's a scoping review. We wanted to just get a sense of what do we know and what's out there. Next, please. Very briefly, we went through a 5-step scoping review process where first we identified a whole bunch of abstracts that seemed potentially seemed to be a fit in our initial screen. They were all double reviewed to see if they did fit. Those that were clearly that didn't fall out at that point were then reviewed as full text. Again, dual reviewed. Then those that made it through the full text screening were charted. We extracted data from them, and the final 100. So we started with about 500 abstracts that made it to the second phase, but about 103 that we included in the analyses we're going to show you now. Next, please. Just very briefly, again, we limited just because we had to US-based work published in 2015 to 21, primary care settings with a focus on secondary prevention of cancer rather than survivorship care, so effectively cancer screening. And do the HIT tools, are the tools described in the reference used to support the various functions that we talked about before, and the cancers that we're focused on. Next, please. Just again, to give you a sense of the kinds of data that we extracted from the included manuscripts, just information about the study and the setting, specific elements of cancer screening, the functions of the tools themselves, the IT tools themselves, which end users were supposed to use the IT tools, and elements, again, of what part of cancer screening was the tool supposed to support. Next, please. And again, very much just to be clear, how we used RE-AIM to identify, to pull specific data out of the manuscripts. We looked at reach, effectiveness, adoption, implementation, and maintenance with a special focus on effectiveness. Did the tool show positive results? And then were adoption and implementation reported, and maintenance as well. Next, please. And again, when we looked at implementation strategies, we organized them according to the ERIC taxonomy, and which I assume everyone listening on this D&I talk knows about. And then we used the Proctor categories for reporting on those strategies, or were those categories reported? Next, please. We also looked to see if a D&I framework or a technology framework was used, was it clearly stated to be underlying the work, and then we looked at any knowledge gaps that were pulled out or were specifically called out in the paper. Next, please. I think it's back to you now, Connie. Yep.
So I'll take it over to briefly here. I just wanted to take a moment to give you an overview of the preliminary results that I will cover today. First, I'm going to describe our sample of references and what they included about the HIT tools impact and adoption, as well as the barriers and facilitators that we came across when we were exploring their adoption. Also, I will go into what we are seeing so far about the implementation strategies used to support HIT adoption, as well as the emerging knowledge gaps that we're identifying in our analysis. So when we go to the next slide, our research yielded a final total, as Rachel mentioned, 103 references published between 2015 and 2021. We did see a decline of publications during the pandemic, and the majority of references were peer review articles. But the thing I want to highlight here is that the majority of the included references were non-experimental studies. Next slide. And of our included references, we did find that there were far more that incorporated HIT tools for colorectal cancer screening than for breast or cervical cancer screening. Next slide. So next, we are finding that when we explore characteristics of where this research occurred, as well as the sample percent of racial ethnic minorities represented in these interventions, we're seeing that this information is underreported. When we break this down by cancer screening type, we find that HIT for colorectal and breast cancer screening mostly occurred in primary care practices located in urban areas, whereas HIT for cervical cancer screening was mostly conducted in rural areas. Next, we found that racial ethnic composition of the sample was also rarely reported or not reported at all across all three cancer screening types. And last, we found that mostly HIT targeting colorectal cancer screening primarily occurred in FQHCs and mostly was not reported for references that covered HIT for breast and cervical cancer screening. So overall, we are seeing that there is a lack of evidence in not only where HIT approaches are used in primary care, but also how these tools are working for people of color served in these particular settings. Next slide. And then as far as the characteristics of the HIT tools themselves, we're finding that most references use EHR-based HIT tools, and the most common HIT function that we identified to support all cancer screening types was clinical decision support, CDS. Secondary HIT functions, as listed here, included risk stratification for colorectal cancer screening, patient decision aid for breast cancer screening, and screening outreach to support activities such as patient reminders, scheduling, and educational awareness for cervical cancer screening. And last, we found that these HIT functions were primarily leveraged during panel management and at the point of care. And this is key because going back to our first research question about how HIT is used to promote cancer screening in primary care, we see here the evidence exists on the type of HIT tools and functions that are being used, as well as the cancer screening activities supported by these tools in primary care, right? But when we go to the next slide, the extent to which we understand the adoption and impact of these tools remains limited, and thus brings us to our first knowledge gap illustrated in this table here. So for each re-aim domain illustrated here, we categorize the percent of references into three groups outlined at the bottom of the table, with low meaning less than a quarter of references reported evidence for that particular re-aim domain, moderate meaning 25 to 50% of our included references reported evidence for that domain, and then high representing more than 50% of references reported evidence. So overall, what this table really shows us is that the literature does not include a lot of information, well, at least currently, about the reach of HIT when it's used for cancer prevention, cancer screening in primary care, as well as there's very little information on HIT adoption and implementation for all cancer screening types, and the evidence varies by cancer screening for effectiveness and maintenance. So now I want to take a deeper dive into the three domains in the middle listed here, specifically to let you all know about what we're learning so far when effectiveness, adoption, and implementation of HIT is reported in the evidence. So when we go to the next slide, overall, HIT demonstrated effectiveness across all three screening types, with the majority of our references showing evidence for positive outcomes related to colorectal cancer screening, followed by breast and cervical cancer screening in primary care. Also, these reported references revealed that there is not a lot of evidence overall on HIT effectiveness for breast and cervical cancer screening. Next slide. And when we look a little further into HIT effectiveness, we find that positive outcomes related to HIT mostly represented clinical decision support used during panel management or at the point of care for all cancer screening types. And then we also identified that there were positive outcomes for clinical decision support when it was used during follow-up care activities related to colorectal and cervical cancer screening. So when we go to the next slide, as I mentioned earlier, since there is a high percentage of references from our sample that covered HIT effectiveness for colorectal cancer screening, we decided to take another look at these references to really see what we're finding about the effectiveness. In particular, here I want to point out that similar to clinical decision support, we're seeing a number of references that reported positive outcomes when risk stratification is used during panel management, at the point of care, and during follow-up activities after colorectal cancer screening referrals have been made. So overall, although the evidence is limited for HIT effectiveness when used for cancer screening in primary care, we do see, as shown for colorectal cancer screening in primary care, that these tools do work. However, when we go to the next slide, despite this evidence of effectiveness, we are finding that there is hardly any reporting on HIT adoption. As illustrated here, there was only 21% of our included references that reported HIT adoption rates. Of those, they mostly focused on colorectal cancer screening. And then overall, the rate of adoption was small, with reported rates of 50% or less for all cancer screening types. So when we go to the next slide, using the integrated technology implementation model I discussed earlier, we identified roughly 34 to 38 references that reported barriers and facilitators of HIT adoption. Here, it's important to note that these barriers and facilitators mostly related to inner context, the nature of the innovation, which in this case is the HIT tool, and the outer context. And those top three barriers and facilitators really underscore that technology adoption is not only impacted by what the tool does or how it's designed, but this evidence shows that the setting in which the HIT is being implemented is key to its adoption for cancer screening prevention in primary care. So to go to the next slide, as illustrated here, inner context barriers and facilitators related to the existing organizational infrastructure and policies within the primary care practice. Next slide. Examples of barriers and facilitators related to the nature of innovation really highlight the extent to which the technology itself is doing what it's programmed to do, as well as its compatibility within the clinical practice setting. Next slide. And last, examples related to the outer context highlight barriers around accessibility to technology support, limitations in data sharing across settings outside of primary care, and the facilitators shed light on the importance of local, state, and federal policies such as Medicaid expansion that impact HIT adoption. Next slide. And last, when we explored reporting of implementation strategies to support HIT adoption, we found that these strategies were reported for less than a quarter of our references. And there were a total of 22 ERIC implementation strategies reported. Most of those strategies were multifaceted, meaning that the interventions featured 2 or more implementation strategies to support HIT adoption. And then the majority of these references featured implementation strategies that focused on promoting HIT for colorectal cancer screening, again, because the majority of our sample did consist of references that covered colorectal cancer screening. And then the last point here, the common implementation strategies to promote HIT among all of the cancer screening types include having centralized technical assistance, conducting small tests of change, which featured things such as PDSA cycles, and then the teams having educational meetings to really help facilitate the training and ongoing knowledge of using the tools. So when we go to the next slide, as I mentioned, we only had a quarter of references that reported anything related to implementation strategies to support HIT for cancer screening. But we're also finding that overall, when this information is reported, there's a high percent of evidence across the majority of these implementation strategies domains listed here. However, as outlined here in our second knowledge gap, there is still limited reporting when these strategies are reported. There's still limited reporting on when the strategy occurs, the frequency or intensity, so the dosage of that strategy, as well as the specific implementation outcome measures related to using that strategy to support HIT adoption. So next slide. And our final knowledge gap that we are finding so far in our analysis is that there is limited use of dissemination and implementation frameworks in our references that covered HIT for cancer screening in primary care. And there weren't any technology frameworks, so any frameworks that relate to technology adoption, acceptance, used in the interventions that were reported in the references for our sample, which really raises a question about, why are these, like related to the fact that, why aren't these resources not leveraged for HIT adoption when there is evidence that supports these frameworks' effectiveness as it relates to using them in the design and implementation, as well as evaluation of evidence-based practices in clinical settings. So now I'm going to pause and pass it over to Amy to take us into our discussion.
Thanks, Connie. Wonderful job there. Next slide, please. And I'm serving as the discussant today and reflecting on these things from the lens of a primary care physician, implementation scientist on our findings for these tools being used in primary care. So as Connie just relayed, the technology used was predominantly electronic health record-based tools, also some other web-based tools. And the greatest things that came out were it's being used for clinical decision support, as well as some other approaches. And that panel management was when this came through the most, but also point of care. The pieces related to the tool's effectiveness, the lion's share of data really come from colorectal cancer screening, much less data to tell us about this with regards to breast and cervical cancer. What really stood out to me from this work is the limited adoption, that only 20% of the studies even reported on adoption at all. And then within those, it was less than half of the sites that were able to adopt these tools. Really shows us this is a major problem if there's the minority of sites can do this work. The barriers and facilitators as are listed there, I'll go through a little bit further on some additional slides, but you see we kind of break them down to thinking of the organizational infrastructure, both person power, and most of these were electronic health record based. So what can our electronic health records do? To what extent can these things function in this way? Then the technology, you saw that there were some issues with it not always doing what it was supposed to do, some barriers where it wasn't felt to be accurate, what it was bringing forth to the staff. And then policy, both what we might say is big P policy, things that are more federal and state, as well as little p policy, the local policies in the practice that supported or inhibited adoption. The implementation strategies, as Connie relayed, often were multifaceted. This is true in much of our work, but it took more than one way to get this into place. And as we might expect, technical assistance was key, as well as being able to iteratively test this and move it together over time. Next slide. Strengths and limitations of the work. we're very clear that this was the intersection, the niche that we were looking at was HIT for secondary cancer screening in primary care, and looking specifically at the effectiveness of these tools as well as the implementation. We used a mixed methods protocol. It was guided by a model, the ITIM model, as Connie showed you at the beginning, as opposed to much of this work that we reviewed that did not have a technology framework or model to support it. Limitations, this is what we looked at, just secondary prevention in primary care. And there were some technical challenges as outlined there that made it difficult to execute all of the pre-specified approaches that we wanted to extract the data with. And as Connie outlined, there were some issues with identifying equity, to what extent this was equitable, even when things like reach and adoption were described. It was not always specified to what extent the population served reflected the baseline population or the population that should be screened. Next slide. So these are my reflections. I was really surprised by the limited use of frameworks. Certainly, there were also many studies that didn't report on their use of implementation strategies, but even that outpaced the number of studies that used a framework or that at least reported on it. They may have used it, but didn't report on it. And would love to see additional thoughts for you to put in the chat in terms of surprises to you from this work or areas that you think, that stood out to you. Next slide. And this just shows, again, the imbalance between the use of frameworks in the studies, the reporting of frameworks. Next slide. In terms of the biggest modifiable challenges, I said, really adoption stands out to me. And in particular, those intersetting factors, the infrastructure and the technical assistance needed, the person power with staff, as well as the tools being updatable. I'm just going to go through the next slides and remind you briefly of what we found in that regard. So next slide. On the inner context, as you can see, there were things that did facilitate this, the little p policies that could support adopting things to HIT, and that there were staff that could help with this. I think of my primary care clinic, and we have to push these things forward to our information technology teams for the whole health system and get them to agree to help support us to put things in. And it is a burdensome process. We don't have staff just in our clinic who are there on site ready to do these things unless we can push it up the chain and get policy support. So those two things of those facilitators, at least for my clinic, go hand in hand. And we see sort of the flip side with the barriers. Next slide. Then again here, the resources, the time, the optimization, customization, to the extent we can make this usable. I think of things like the system usability scale. How usable is this for the clinics to do? It makes a lot of difference. And then we see, the burden in keeping it up, who's going to do that, and the inaccuracies obviously being a major issue. If it's inaccurate, I don't want to use that. Next slide. And then here again, we see things related to usability on the barrier side, and on the facilitator side, elements that push clinics to have a value, to have the value proposition to use this, that they're not just paid only for fee for service when there's an FQHC or the incentive to do some more population management. I think those things push clinics to have a value to incorporate these things. Next slide. So then in terms of important next steps, there's many, and I want to get us to the Q&A so we can hear from you and talk more there as well, but I'll just touch on one and encourage you to keep putting other things in the chat about ideas for the challenges with this work or potential solutions. So next slide. The one thing I will focus on is in our gap related to the implementation strategies, the elements that we can that we can specify according to Enola Proctor's elements and domains of specifying implementation strategies, being more clear about the dose and the implementation outcomes affected, as this particularly relates to our notion of mechanism with this work and how this work is accomplished. Next slide. And now I'm going to pass it back to Connie to wrap things up before we move into the Q&A.
Yes, thanks, Amy. Great job, by the way. So we just want to give a special shout out and thanks to all our co-authors again, as well as our funders listed here. And if you would like more information about this research, we do plan on publishing this work. You can reach out to me directly. My email is provided here. And I'm going to turn it over to NCI so we can go ahead and get into the Q&A.
Thank you, Connie, Amy, and Rachel. What a wonderful presentation. And I have to say, when I saw all the slides, I absolutely didn't think you could get through it in 30 minutes. So great job, ton of information. I'm going to encourage everyone to put their questions into the comments or the chat function. Rachel has responded to some of the questions as we were going through, which is great. I'm sorry, I'm kind of being cut off here. But one of the questions that I don't know that was fully answered was someone wanted to know if you could elaborate on what it means to be activating the CDS tools. Were they part of the clinical workflow?
Yeah.
Can you share a bit more about that?
Yeah, why don't I take that one, Connie? Is that okay?
Sure, sure. Yeah.
Yeah, I mean, we talk about, I'm not sure even where the term activating came from. I mean, these were all tools that were, I mean, effectively either turned on in the user's electronic health record. You know, they were either, again, go back to like what the tools were used for. They were either point of care alerts or panel management, like data roster tools, or similar tools to help with follow up. Hey, this patient didn't get, we referred this patient to go get a follow up, to get a culpo or something, but we didn't see that happened. That hasn't happened yet, right? So the tools were turned on in the EHR and could be used by the folks, who at least had access to them in the study. The web-based tools, there was a question about that as well. That was more like, those were more like a resource. Most of those, and Connie, tell me if I'm getting this wrong. I remember my recollection is that most of the web-based tools were effectively, like patient decision-making tools. Like, should I get the following screening?
Exactly.
There would be kind of a web-based tool to support that. So those were just either available or, and then the question is, were they used? So I'm not sure if I'm not, I want to maybe, if that's not answering the question about activation effectively, please pipe in and let us answer that.
And Rachel, I'm just saying we have the barrier in the outer context of cumbersome to activate and update HIT tools. So maybe just speaking to that outer setting barrier.
Yeah, that's interesting. I mean, given that, these were all studies of how folks were using tools that were in place, I'm not really sure how to think about that, I guess. Like I think,
Rachel,
yeah,
I think, please. Yeah, to my understanding from what I'm seeing, I perceived it as activating the actual like alerts and reminders used to, whether help with providers scheduling appointments, or alerts or reminders to help with, identifying eligible patients that are due for their screening. So maybe when there were updates to, customize those features, there were probably cumbersome challenges to activate those customization features for those specific CDS tools. So
I'm sorry.
Yeah, we have to do a little bit more digging on that, but from my understanding, that's what I'm seeing so far. Yeah.
I don't recall seeing a lot of articles that talked about, boy, it was hard to set up this tool. But we do know, I mean, I have read, papers that look at, we certainly know that the quality of data in the EHR drives the quality of these, and these tools that are driven by, that are tools that are driven by EHR data. We certainly understand that the quality of the EHR data is going to drive the tool. And I've seen some papers out there about that. What we were really more, I think that's the correct answer.
All right, we've got another question in here related to health equity. The person who submitted this was interested in understanding how to deal with health equity in future research. Do you have suggestions? Should you be oversampling? Should you be trying to group for effective, oversampling groups for effectiveness testing, interviews, et cetera? What are your thoughts on that?
Yes, so yeah, I could take it first, and then, Rachel and Amy, but I think first, given what we're seeing with the results from our scoping review, we need to do a better job of just overall ensuring that racial ethnic minority groups are represented in these studies. So making sure during the recruitment process, we're, doing the outreach that's needed to ensure that they're also included in, not only the control group, but also the intervention group as well. So I think right there, it just starts with the sampling and recruitment piece. And then to, ensure that we're addressing health equity in the interventions, not only looking at its overall effectiveness for the entire sample, but, breaking it out by, social demographic factors and, race and ethnicity to understand, what specifically was it about, leveraging, for example, an EHR-based tool and CDS that really helped us with our outreach to improve cancer screening for certain minoritized and marginalized groups. So, doing that extra level of stratification in the analysis to really, sparse out, what exactly is it in the intervention that's working. I think that's another step. Once again, we didn't cover that, collecting that level of the data in this scoping review, but I think that could help, move the needle on that effort. Rachel and Amy, and from
Well, I would just add this. I mean, one thing we found was that most of the papers didn't even report race ethnicity. So we have no idea. Like there's the literature has just this huge, not just a knowledge gap, but a knowledge chasm of are there differential, are there differential impacts in different groups? Like they're not even reporting. Right. So at a minimum, let's start reporting. Yeah, this whole, at a minimum, let's start reporting that. I'm seeing a lot of questions about what's interesting to me about some of the questions I'm seeing in the chat about have these tools been translated? Again, I want to be clear that a lot of the tools we looked at were provider facing tools. These were tools targeting clinic, decision support. They were mostly provider facing tools, not patient facing tools. So the translation element seems more relevant to the patient-facing tools. But I think the take-home I want folks to get from this talk is what you guys are asking about is like, we're not even ready for that. The literature, I was shocked by these findings. There is so little written about the effectiveness of using HIT-based interventions to improve cancer screening in primary care, and even less about how the tools are adopted. So these other questions, I agree, they're all important. But we have some basic ABCs we have to deal with. Like we don't even know if we, so while I appreciate all of these questions, I just want to call out that there are some basic science evidence gaps here that maybe need to get handled first. Like, do these tools work even in any settings, let alone in more diverse settings? So I just want to call that out. There's and the quality of EHR data, that's a great question. I've certainly seen that in some of my research, right? That if the EHR data is not, but the point I want to call out here is this: in terms of demographics, preferred language, that's not what the tools we were looking at were for. Again, they were mostly for point of care identification of patients who are due for screening, or panel management for patients, who are overdue and need to be brought in, or follow up on care for patients who, in broad strokes, that's what these tools are for. So the demographics and preferred language I don't see how they'd be relevant to those kinds of tools. And then what I would say is, your point's well taken, right? Is that if EHR data is not complete, then the quality of the tools are not going to be as good. But I would say this: if you've got a person's health record that doesn't have their most recent screening data, that's the result. That's what you want. Then a tool that says like, hey, that says the EHR doesn't even include this patient's screening data. Like, what's going on there? So in a way that's not necessarily missing data. That's the data. The data is that there's no information. I hope I'm making myself clear.
Yeah, I thank you, Rachel. I wanted to give Amy a chance to expand a little bit on sustainability. There was a question from Natalie of whether the studies, if you found any issues related to sustainability. So
yeah, happy to do that. And I don't know if we want to go back to the slide real quick. It's slide 23, if that's easy enough to do. If not, I'll just speak to it verbally. But yeah, our knowledge gap number one that we presented today was that There's very low reporting on the re-aim domains of reach, effectiveness for most, adoption, implementation, and maintenance. So less than 25% of the studies that we looked at reported on maintenance. In terms of, if we think of sustainability versus just sustainment, there were a couple of things related in our qualitative. So there was one piece in terms of a barrier on the burden to HIT maintenance as well as develop. So to the piece that if the research team was able to bring this in and build it and get it in there, but then there was no one left in the clinics who could sustain it, then that would be a sustainability barrier. Rachel, Connie, I don't know if there's anything else that you wanted to comment on related to sustainability.
Based on our preliminary results, like we have outlined here, when we say it was like less than a quarter, it was only like 5 references, if that reported anything on sustainability. It was just very low. So there's a huge gap there in the evidence to address that.
Huge.
So,
Oh, and Cindy, can I address the question about lung cancer? Someone asked if we considered lung cancer screening. Cindy, may I jump to that, or did you have another point?
sure.
Really quickly, Kate, we did consider looking at lung cancer screening, and we had to limit it for scope. We there was only so much we could do. We just chose not to look at it because we could only do so much. It was just a matter of keeping the work manageable.
So Mary actually has posted a really good question about if you could think about what type of studies or research needs to be done to fill those knowledge gaps. What's the right mix of qualitative and quantitative?
Yeah, so I can take it. So I think for in regards to the type of studies, for research done in D&I, that we're well positioned to really leverage mixed methods studies as well as qualitative studies and quantitative studies. But I think the qualitative studies could really dig deeper into what specifically are we lacking when it comes to understanding HIT adoption. When we look at these implementation barriers and facilitators, how are they linked back to the implementation strategies that we identified? And like we said, like there was a lot of information lacking in regards to implementation outcomes. So looking at different factors such as like feasibility and acceptability, we can really, begin to link, those outcomes with the barriers and facilitators if we use a blend of mixed methods. I hope that answers the question.
Can I tag on real quick as well? I thought that was a great answer, Connie. But Larry, one other thing that struck me as I was looking at our barriers and facilitators, what we've learned so far is a lot of them seem related to the process and not as many of them seem related to the stakeholder priorities. I worry about understanding the value proposition for our stakeholders a little better. And we see such a diversity of areas where these tools can target panel management, point of care, follow-up. Understanding more about the most critical needs to our stakeholders, I feel would really be useful to hone in on getting these tools to be more usable for those elements of the processes.
Rachel, anything to add? I'm ready for the next question.
Yeah, no, I agree with those guys. I mean,
okay.
Yeah.
So Natalie had a question. If you have kind of a takeaway of the do's and don'ts in developing HIT tools to promote adoption, is that just something else we need to do more research on, or what's your take on that?
I think that's a gap. I think that's a gap as well. I mean, it's interesting that what that would fall in, is when we're looking at the I guess when we're talking about the various barriers, one of them is sort of the quality of the tool. And I don't recall seeing a lot of articles that talked about how some of them did talk about how they developed the tool, but I don't feel like it was I don't think anyone's I didn't see any stuff where they formally tested different strategies for developing IT tools and to make them more adopted. I think that's the short answer. Connie and Amy, do you have anything you'd add there?
Yeah, I would just simply say, to reiterate, this is just something that we need to do more research on, because that is just what we have to find more evidence about. Like, to our understanding, these tools have already been in place, so we didn't really get too much information about like their development and like the pre-implementation of these tools. So I think that just leveraging more research priorities that really seek to understand, this gap will really help fill it.
One thing I would say here, Nat, and I could be, this is a guess, but having written one paper about specifically like the process involved in just simply implementing an IT tool myself, not focused on cancer. I think there may be a publication issue here, right? That folks don't necessarily think, oh, I need to publish about how I developed the tool, a given tool. Like that, folks may just not even think that that's, like I'm not going to, people may not even be considering writing that up, even though I do think it's important. I'm not, I don't know that there's a whole lot of literature out there on processes used to develop IT tools. I could be wrong. I mean, that's not, but but when we look, what we looked at again was like, barriers to it, who reported on barriers to tool adoption, and what are the kinds of barriers that they reported on. And we did see, some of the stuff, one of the things that did get reported on somewhat, it's all not a lot, but somewhat, was around the content of the tool itself. So clearly that's an issue, right? That we need to think about how the tools are developed. But I would say, really, I think the take home from this talk is that this is a field that is really underdeveloped, much more than I thought it would be going into this process. Cindy, I'm going to get back to you because there's lots of questions coming in. I'd like to.
Yeah, so there's a lot of questions around usability, and really trying to dig into whether or not the implementers found it worthwhile to activate the tools. So, Amy mentioned that this is really what we're talking about, getting to the end user. If an HIT system isn't being maintained, they may not see value in using it. Would you like to comment on that?
Yes.
I'm not sure we know. I think that's what this results show us. So again, like the take home here is that there's a lot of literature on colorectal cancer and a little bit on the other two cancers around effective tools for supporting cancer prevention and primary care, effective IT tools. There's, but where there is literature, they show that tools are effective when used. So right, it's again need a lot more work in breast and cervical around what kind of tools are effective. But the overall where right. But I think that the issue is really this is an implementation science issue, right? If we've got tools that are effective when used, then what is going on with why folks aren't using them? So I see that maybe folks are not enthusiastic about using the tools. Of course that's possible. We know that perceptions of a tool's usefulness drives future use of the tool. But yeah, so again, what my overall take home here is that we need to study this. Connie and Amy, would you want to add anything to that? It was not a super answer on my part.
No, I mean, I would just, simply add, just from the barriers and facilitators that we identified in our results, we understand the context matters, the setting matters. So if the tool is not compatible, in a low resource primary care setting, there's more research that needs to be done to explore why it's not compatible, to explore, what are those limitations that, make it hinder it from being used effectively. And then, if it's working in other settings, what's driving what's working in those settings. So going back to the question about, is it mixed methods? Is it quantitative? It's a little bit of everything that we need to do to really, dig in it. I mean, this review shows us that the gaps are there, and, we have the resources to really, go in and research and evaluate how we can help close those gaps.
I'm going to add one other thing here to respond to this question about activation. Again, consider that these were all papers on how that were about these tools, right? They were interested in these tools, usually effectiveness, but somewhat adoption. So the question, did implementers find it worthwhile to make the effort to activate them? They certainly wanted people to activate.
Rachel, I can't hear you. Did you just go on mute?
No.
Now you're back. We can hear you again.
You're back.
Okay, sorry about that. My internet, of course, classic timing, right? So I'll repeat myself. The question about making it worthwhile to activate the tools, consider that we were looking for studies of tools, right? So in any of these circumstances, the question is, the folks who were trying to get the tools to be used were certainly going to make the effort to activate them because they wanted to study them. I think, and what I think your question points to is that even what we learn from this scoping review is relevant to tools used in some kind of a research context. And that the next step, I think, in the field is, well, okay, what happens in the real world setting when there's not necessarily a research team trying to get folks to use the tools? Because we know adoption is going to be worse then, or we can assume.
I want to take the questioner's prerogative because this is work that started from the Consortium for Cancer Implementation Science, from the action group that you have helped co-lead, Rachel. Can you just give a little bit of background of how this all came to be? I mean, this wasn't something that just started last year during the consortium. And, are you thinking that there's additional work that action group is going to be able to do based on this scoping review and that citation that people are asking for?
I'm sorry, which citation I'm missing?
You're wondering, when is this going to be made public?
Well, as soon as we can write it and submit it and get it accepted. I'd say probably within a year. It takes a while. You guys all know the publication process is slow. So the action group, the technology action group was part of the CCIS. Did I get that wrong? It's the IC3. I always mix them up. It's the CCIS.
CCIS is good.
Thank you, Cindy. And we 2 years ago, the action group, kind of got together and said, what do we need to do to move the field forward in terms of the use of technology in cancer prevention or cancer care, really, and the role and how implementation science, how do we move the field forward, implementation science forward in terms of if these are these effective interventions, and do they, and what we came to is we don't even know. We were we don't even know what's out there. And so we said, what we kind of landed on is I think our first step is to assess the literature. Where are the gaps in literature? So in terms of what's next, I think that what I think we might want to do in the action group is think about what do we think is the top priority, where, what are ways to efficiently learn more, what is the research that needs to happen next? That's a short answer, Cindy, but it's a huge task, right? Building a field of research. This is many years of research to understand this better. Maybe we could think about as ways to, expedite the research. Maybe we can do study. I think studying the impact of these kind of tools, maybe you don't need a 5-year study. Maybe we could do it in a shorter timeline. Maybe there are ways to learn more efficiently. So it doesn't take us, 10 years before we understand how to use decision support tools. That's I guess I guess my answer to you, Cindy. The sort of next steps are figuring out what to do next to move the field forward. Now that we understand what huge gaps there are in knowledge.
Excellent. So I want to see if there's any more questions coming in. There's a lot of great comments and discussion going back and forth in the chat. What do each of you have one last thing that you would like to say about this scoping review that you'd like to share? Words of wisdom? Other than more research absolutely needs to be done. This really does show that there's a dearth of research in this area. So.
Well, I would just say this is sort of my soapbox, but given that we are showing that IT tools can improve cancer screening outcomes, right? Improve rates of guideline concordant cancer screening. We do need a little more research on how to use, on the effectiveness of such tools, because we did kind of look at tools at different stages of workflow. But the fact that that there's so little reporting on how these tools are used, it's just a huge knowledge gap. And if we have an effective intervention, how do we get people to use it? And yeah, I mean, Cindy, I know, I wish there was a more sophisticated answer, but I think the answer is we need to learn this. If these are effective interventions, why aren't they being used? How do we help them get used more effectively? Connie and Amy?
Yeah, and I would just add, this research really helps to identify those gaps, where there's a lot of gaps on understanding the adoption, as well as the implementation. We're seeing evidence around its effectiveness, but it's not a lot. So, once we do get this paper published, we hope that it could really help to, move the research agenda forward to really help to bridge these gaps, because, we did a lot of work here to just lay it all out there. Now it's time to really, take those next steps to, tailor our research to really address, these emerging knowledge gaps that we are identifying.
Thank you.
And I can add 2 quick comments. One is on the stakeholders' priorities and understanding how these tools could really fit their priorities best, because we're hearing that it does then take some policy and some person power at the local level to get them to work. So if we're not right on target with some of the more important priorities of how to do this and which element, panel management, point of care, and maybe it varies by different types of clinics, that's really key to know. And then the equity piece, and my thought on what really should be measured there is at least how representative, how equitable the population identified and touched by this tool is as compared to the general population of the clinic, at least being transparent about that representativeness of reach.
Excellent. So there was one last question about whether the training component was included during pre-implementation phase. I'm not quite sure.
I got that.
Sure. Okay.
Sure. I mean, Sandra, that would really relate to that we looked at that. That's a training is a implementation strategy. So we, we looked at how often people reported on the implementation strategies used to enhance use of a tool. It was basically fairly underreported. That's the answer. But we will report in the paper on what the different strategies were that were used to enhance tool adoption, and training is certainly one of them.
Excellent. Well, what a great hour. Thank you for sharing a preview of a future publication and an outcome from the Consortium for Cancer Implementation Science. Really appreciate all the hard work you put into this. And with that, I'm going to turn back over to ICF to close us out.
Thank you, everyone. Thanks to our presenters for a great presentation and to our audience for a great discussion. Please note that the webinar from today will be archived on the IS website, so please be on the lookout. And with that, please feel free to disconnect at this time. Thank you.
Thanks, everybody. Thank you, Amy and Constance. Thank you, NCI.